So my name is Erica Phipps, and I serve as Executive Director of the Canadian Partnership for Children's Health and Environment, or CPCHE. I'm really happy to be here today. Thanks, Tim, for getting us started, and welcome everyone. We're really glad to see such a great turnout today for our third and final webinar in our Setting the Stage for Action series. So these webinars are being convened as part of a collaborative project that is joining up CPCHE, the Canadian Partnership for Children's Health and Environment, and our multiple partner and affiliate organizations, with another collaboration, the Prenatal Environmental Health Education Collaboration, which is a research consortium that has, with support from CIHR, done a whole body of research to better understand what is happening in the context of prenatal education in Canada with respect to toxic chemicals, pollution, climate risks, and other environmental threats to reproductive and fetal and child health and development. So it is in that context that we are convening this conversation today, which is one of multiple streams of activity that we have going on in this PEHE-CCC project. I'd like to acknowledge Health Canada. The Chemicals Management Program at Health Canada is supporting this knowledge mobilization work. And I also want to give a shout out to Jack and others at CANE, the Canadian Association of Nurses for the Environment, which has stepped forward to serve as the lead partner on behalf of both CPCHE and the PEHE Collaboration and administrating the grant funds on our collective behalf. So welcome everyone. I'm going to now hand it over to Jack to get us started in a good way.
Thank you, Erica. So I'm not turning on my camera for this because it's more important for you to listen than to see. And so I want you guys to get comfy and just think of the words I'm saying, because we're going to think about the land we're on together. So when you step outside your door each day to interact in the natural world, do you consider who may have walked this land before you and who will walk this land after you are gone? Do you acknowledge your personal relationship to the land? Do you think about how the land supports your health and well-being and that of your family, community, and all non-human entities within the web of life? It is through these relationships to the land that we come to understand that everyone has a role to play in taking care of the land. Being an environmental steward is everyone's responsibility. How we honor the land and maintain its health so that we can nurture future generations is up to each of us. So together, let us honor the land while respectfully acknowledging the original inhabitants who have been the stewards of the place we call home for thousands of years. I'd like to acknowledge that I am personally grateful for living on the lands of the Anishinaabe, Cree, Dakota, Dene, Oji Cree nations, and the homeland of the Métis peoples. And I'm coming to you guys on behalf of CANE. And at CANE, we commit to righting the wrongs of colonialism by strengthening our knowledge of and relationships with Indigenous peoples where we live, work, and play, and by adopting decolonial and anti-racist practice and discourse. Therefore, as my part in the project, I have been working towards this. And while we've been working towards all of these webinars and gathering insights, we've really been trying to put it in a good way with that kind of lens. So back to you, Erica.
Thanks so much, Jack. So today we have a really exciting lineup. We have 4 presentations for you that will be, our presenters are going to be highlighting materials that are in development, strategies in use. We are looking to you to share in the chat and in our conversation towards the end about resources that you use or wish you had in the context of engaging on environmental health topics with prospective parents, but also more generally in the communities with whom you work. So we also have towards the end a really great example of practical on-the-ground work to adapt education and advocacy in local contexts, which is also a really important thread throughout this work. This webinar today is really important. It helps us move from the findings from the PEHE collaboration research, which not surprisingly showed us, as explained in webinar 1, that prenatal environmental health conversations are not routinely happening in Canada. So prospective parents aren't hearing about topics that may affect the fetal development and child health in the routine interactions with prenatal care providers. And prenatal care providers aren't initiating those conversations for multiple reasons. One of which is that educational materials either are not robustly available, or folks don't know about them, or don't have the sufficient training and support to be able to mobilize those educational tools with the patients and clients and communities with whom they work. So that's our focus today. We hope to have lots of opportunity for interaction at a minimum through the chat. We're going to try to preserve some minutes at the end for a panel conversation. But I will move ahead now and introduce our first set of speakers. It is my great pleasure to welcome Dr. Roxana Ahmed, who's been a long-term collaborator and researcher as part of the PEHE Collaboration with expertise in health communications, and Angelina Sarwar, who was a student at the time that this PEHE research kickstarted, and Angelina is going to be sharing some of the work that she led and supported in her role as a student at the University of Ottawa. Over to you, Angelina and Roxana.
Yeah, thank you so much, Erica, and thanks everyone for being here. Very honored to have the opportunity to present. So today we're going to be jumping into the environmental scan of prenatal health education resources. And as Erica mentioned, this is the work that I had the opportunity to kind of take initiative and start during my time as a student at U of Ottawa, and then ultimately I ended up doing my master's in public health at McGill University. So next slide, please. So today I'll be starting off going into the objectives and methods of our research and ultimately why we decided to uptake this environmental scan on existing health education resources within the prenatal field. Next slide. Yeah, so the research objectives were to ultimately identify health education resources that prenatal healthcare providers can use to incorporate environmental health education into prenatal care and encourage the development of novel resources where suitable resources are not yet available. So ultimately, we wanted to identify authoritative preconception and prenatal environmental health education resources, review and assess these resources based on their themes covered, whether that relates to accessibility, understandability, and actionability, and document any identified resource gaps. And the focus of the environmental scan was on materials produced in Canada by relevant government or non-governmental organizations. Next slide. Thank you. So the way we decided to do this was do a qualitative assessment that has two different sides to it. So the first thing is we employed a dual-layered evaluation strategy to assess the identified prenatal health resources. And the first aspect we did is our team of researchers decided to use a quantitative tool called the PMAT-P, where resources were evaluated using a modified version, and that is the Patient Education Materials Assessment Tools for printable materials. And this tool ultimately focuses on two different sides of evaluating the resources. The first is understandability, and the second is actionability. So with regards to understandability, we wanted to assess whether consumers of diverse backgrounds and health literacy levels could process and explain key messages. And then with actionability is we wanted to evaluate if users could identify specific actions to take based on the information provided with the health education resources. And while we have this tool, and we thought it's going to be really beneficial to look at the understandability and actionability, we wanted to get a real-world perspective of practitioner insights and to address kind of the lack of pragmatic and applied insights that the PMAT tool may not necessarily cover. So we decided to get the opportunity to have a few practitioners to review these materials as well. And they review these materials based on effectiveness, the accuracy of the information, and the clinical suitability. And we wanted to get a broad spectrum of healthcare practitioners within maternal health. So that's, your OBGYNs and family physicians, midwives and nurse practitioners, registered nurses and licensed practical nurses, and public health professionals. And the methodology we used to employ here was to have 2 to 3 reviewers per professional practice to evaluate a subset of the resources using a brief rating form that we had developed internally as a team. Next slide. And I'm going to pass it on to Dr. Roxana Ahmed to talk about some of the results we had. Roxana, I believe you may be muted. Apologies.
Yes, thank you. Greetings, everyone, and thank you, Angelina and Erica, for the introduction, and Angelina for setting us up. It is a pleasure to present alongside colleagues today. So, next slide, please. So when we attempted at the quality appraisal using the PMAT tool, we found that most prenatal environmental health materials focused on a few traditional hazards. And we also were able to reveal gaps in addressing emerging concerns. And we also found that they generally blend toxicant information with practical behavior change guidance. Next slide, please. So if we can summarize this table as across the 5 domains, as far as understandability of the materials is concerned, the materials were generally understandable, but the experience varied. Some sections were highly accessible, while others introduced barriers, especially where text became dense, visuals were missing, or terminology became more advanced. Addressing these inconsistencies would improve clarity and make the materials more uniformly user-friendly. As far as actionability is concerned, we found that it was inconsistent because some materials offered clear steps, checklists, examples, and tools, while others relied on vague recommendations with little how-to guidance on or pregnancy-specific actions. Web pages were the dominant format, offering easy navigation with collapsible sections and embedded links, but some lacked visuals, contained broken links, and relied on static rather than dynamic content. We also found that many materials reference pregnancy, but were not truly pregnancy specific. So pregnancy focused resources tended to be more actionable, while general audience ones forced readers to infer how the information applied to pregnancy. So if we take the 5 domains together, they show that the materials are generally clear and easy to read, but they vary in how actionable they are, rely heavily on static web pages with some quality issues, and often mention pregnancy without providing pregnancy-specific guidance, which makes usefulness uneven or especially for pregnant readers. Next slide, please. As far as literacy levels were concerned, we found that they were generally accessible with plain language, the materials, and clear formatting, but some materials were text dense or reading at a higher reading level. And while a few resources used effective visuals, such as like icons and checklists, many web pages did lack visuals, and some PDFs were visually cluttered. Language availability was limited because only a few materials were offered in French and very few in other languages, while others are there were some community-specific resources, such as First Nations Guide. Most materials lack cultural tailoring or examples that reflect diverse populations. So overall, the materials showed limited visual support, uneven literacy demands, very restricted language availability, and minimal cultural tailoring, which together can reduce accessibility and relevance for many users, especially those who are non-English speaking or from diverse cultural backgrounds. Next slide, please. So the key findings from the practitioners' review told us that the practitioners viewed the materials as generally accurate and valuable, especially for their practical relevance. They also thought that the practitioners would integrate them into care by sharing links on organizational sites, screen sharing with patients, printing when needed, and sending resources to clinicians for e-consults. So the practitioner's feedback suggests that resources are useful but need clearer and more actionable design to better support real-world clinical workflows. So the key message is that the materials across clinical and community settings need more consistency, clarity, and regular updating so providers can rely on them, and strengthening evidence-informed, culturally relevant, and accessible design will better support prenatal environmental health conversations. Yes.
Excellent. Thanks so much, Angelina and Roxana. We do have a couple of minutes if there are any. Oh, I'm sorry. Roxana, please continue. I thought you were pausing for me to jump in for Q&A.
Oh, no, I think, it was I guess the sort of like the lag, maybe on my side, didn't give a cue to move on to the next slide. But basically, there's the implications. This is the slide with the implications for all the key findings from our PMAT quality appraisal and also the practitioners review. So basically, I'll just reiterate the key message that we can deduce that materials across clinical and community settings need more consistency, clarity, and regular updating so that providers can utilize them. And it will also be helpful to strengthen evidence-informed, culturally relevant, and accessible design, because that will help better support prenatal environmental health conversations. Thank you so much.
Thank you. So yes, thanks very much for an informative overview of the learnings in terms of what the landscape looks like right now or over the past few years in terms of resources. Is there anybody who would like to ask a question about the information presented? Feel free to unmute if so. And as we continue, if something occurs to you or if you have some comments or ideas to suggest, please, we do invite you to use the chat as well. Great. Well, one of the observations that I would make, particularly looking at the implications here in terms of that consistency and wanting to ensure that information is evidence-informed and up-to-date, is a conversation that we've been having across the various gathering insights sessions we've been convening with providers and community members, is the role of professional associations and perhaps others to vet some of those resources and make them available through association websites to save individual providers that task and homework of checking to make sure that a resource is actually evidence-informed and is suitable and sufficiently up-to-date for use. So these are some of the learnings that we're gathering as we try to stitch together sort of an outline of strategy going forward, because one of the key things that we're trying to do through our PEHE-CCC project right now is to chart that collective map for action. So what are the gaps? We know more from the PEHE collaboration what those gaps are. What are the actions that we can do, that we can work on together across sectors to fill those gaps and to better support both community members and practitioners to engage on environmental health issues during those really vulnerable periods of preconception and prenatal development. So we're now going to move to the next presentation, which is actually from me. So I'm going to share some of the work that we've been doing within CPCHE and also including our learnings over the years on environmental health educational resources, particularly those geared towards preconception and prenatal care. So just a quick word about CPCHE. We are not an organization per se. We are truly a collaboration. We've been working for a quarter of a century, bringing together the diverse expertise and experience of our partner and affiliate organizations towards our shared goal of healthy and sustainable environments for kids in which to live, learn, play, and grow up. So we do knowledge mobilization work as well as policy advocacy. Across this work and recognizing the emerging nature of evidence about the connections between toxicants and health, particularly in the complexity of life stages, CPCHE really focuses on both precaution. We want to be better safe than sorry in the face of evolving evidence and always uncertain connections. The causal connections are not always there, but we know certainly that prevention is essential, especially during those vulnerable early life stages of fetal and child development. So against this backdrop, probably almost 15 years ago, CPCHE launched what we affectionately refer to as our Top 5 Tips initiative. In our work, frontline with service providers to support environmental health education and awareness at a community level, we recognize that parents and guardians desire simple, non-ambiguous advice. Lots of competing messages can be overwhelming with chemical names and so forth. And at the same time, service providers were seeing a need to increase their own capacity. They're hearing questions from community members, but were not always feeling equipped with the training or knowledge that they would need to engage on those issues with the people they serve. So what we set out to do was to create a simple and an informative plugin for prenatal care specifically and with broader use, so that service providers wouldn't need to do all that legwork and homework, but would have something that they could simply plug into prenatal classes, for example, and their work on the ground in community. So we actually got funding from the government of Ontario. This was back at a time where governments were hearing a lot about environmental health risks, toxic chemicals, and recognizing that populations needed to be better equipped to engage on these issues. This is why the project began in Ontario. We sought to create the top tips by working side by side, not only with CPCHE partners, but also with public health units and other frontline service providers, including piloting all of the resources at a community level before their finalization. So what we wanted to do, as I mentioned, was to support preconception prenatal education, and at the same time, build that sort of general public awareness and literacy on toxics and health. We wanted to focus on practical and accessible measures rather than specific chemicals of concern. So the original top 5 tips included bust that dust. So focusing on the evidence that chemicals from consumer products and lead in paint and all of other sorts of hazards, much of it ends up in house dust. Kids are on the ground, hand-to-mouth behavior. They are more disproportionately exposed to those contaminants. So simple measures like frequent wet mopping, routine dusting and vacuuming can help to curb those exposures to that whole host of chemicals that end up in house dust. Get drastic with plastic. Our focus there was on encouraging not microwaving or heating food and drinks in plastic, regarding the concerns for those plastic chemicals to migrate into the food or beverage. Encouraging fresh or frozen instead of canned foods, recognizing that the lining of food and drink cans contain bisphenol A. Go green when you clean, promoting simple, less toxic and really much cheaper cleaning methods, such as using vinegar and baking soda, avoiding fragrance chemicals, quote unquote air fresheners. Renovate right, the concern there about pregnant women and children being exposed to renovation dust and fumes, encouraging sealing off the house, making sure that vulnerable people are not in the space during or directly following renovations, and doing thorough cleanup and airing out of the space. And then finally, dish safer fish. This will be familiar for many of you who do frontline work in a prenatal context. The concerns are around mercury in fish, so guidance about choosing safer fish species. And then eventually we expanded the top tips, and we hope to do more of that. We did include a 6th tip on reduced radon, which is the second leading cause of lung cancer, an invisible radioactive gas that can build up to harmful levels indoors. So the suite of top 5 tips included a brochure, which we did together with Today's Parent magazine. We turned the brochure into plain language tip cards that are available in 7 languages. And then the video is a 13-minute video that is meant to plug into prenatal classes and other educational opportunities, originally in English and French. But we had a request for translation into Anishinaabe language as it was being used on the ground, as featured in our webinar 2 by the Anishinaabe Nation and Thunder Bay District Health Unit, among others. So right now we have a current opportunity. Against the backdrop of what we know from the PEHE research, we're revitalizing the top 5 tips. I can go to the next. So just briefly, so, webinar really went into this in detail, so I encourage you to check that out. But the work that the PEHE collaboration did through a survey of women of reproductive age and then a similar survey with prenatal care providers importantly showed that the prenatal period is viewed as an opportunity for prevention. Women and providers feel that day-to-day exposures can interfere with child development, and they also feel predominantly that pregnant persons can reduce those risks by reducing exposures. But not surprisingly, both providers and women face barriers. So on the part of women respondents, again, most felt that risks can be reduced, but only about half were taking protective measures. Limited awareness of safer option was one of the top reasons for lack of action. So again, flagging that as an opportunity for doing better on educational materials and strategies. And then from the side of prenatal care providers, again, they really felt that risks can be reduced during pregnancy, yet more than a third reported not handing out or providing informational resources. And the vast majority said that they lack appropriate informational resources, and they also lack the knowledge or training to engage on these issues. So currently we are working to refresh the top tips. First, we of course like to expand to additional topics such as pesticides and other issues of environmental health concern, but recognizing that providers, frontline healthcare providers, but also social service providers who are interested in engaging on environmental health issues are typically not trained on these issues. They don't necessarily have the background that they need. So together with, it's really a collaborative effort. We've had support from Kane students and a number of CPCHE partners preparing backgrounders for each of the tips that provide an overview of the scientific evidence and help providers understand the why and the how of the tip measures that are included in the resources. We are also working through the current effort and with the support of our equity team. We have a team of folks who are frontline providers, people with grounded expertise, people in professional roles, working together to define strategies through which some of this educational work can expand beyond the individual protective measures to those more upstream questions of why are there toxic chemicals in our day-to-day products and the places where we live, work, and play, and what can be done from a social justice and rights-based framework as well. So we hope as we continue to work on the top tips to better equip service providers, but also to include not just the protective measures, but also those pathways for policy engagement. How do these decisions get made? And most importantly, how can community members find those pathways to make their voices heard? So with that, I want to thank you and invite any questions that you may have. Yeah, thanks, Tim. Tim's just put a link to the top tips collection in the chat there. At any point, if you have ideas or feedback on those resources or what you would like to see in the next generation of CPCHE resources, please do reach out at any time. So I'm not seeing any questions. So let us move on to the next presentation. My great pleasure to reintroduce Dr. Jack Avanti-Struss, who is past president of Kane and a real leading force in terms of perinatal health, on environmental health and climate-related topics. And Jack's going to be sharing the PEHE-FAT. Over to you, Jack.
Thank you so much, Erica. So in the meantime, I'm actually putting a link to the PEHE-FAT in the chat. So while I'm talking, feel free to scroll down to the bottom of the page and take a look as I'm chatting. And because I only have 8 minutes, there's a video recording of the launch of the PEHE-FAT that explains the nitty-gritty of how it was created. But as we heard from the beginning of this presentation, there is a need for evidence-based resources for healthcare providers to be able to use in the front line, but also health and social service providers. So grateful that Université de Saint-Boniface, Kane, and Health Canada contributed financially to be able to develop this awesome PEHE-FAT. But what is the PEHE-FAT? So if we look at the PEHE-FAT, I'm not going to talk about the problem area. Erica talked about that. But in tandem with that environmental scan that was being done, we also completed a rapid review to see what tools were actually available. So the environmental scan looked at educational resources. We wanted to see what actual tools were there to assess the perinatal population or anybody during the transition to parenthood. And we found very similar results. If there were tools, very few actually included environment and very few included climate change, disaster preparedness, all that environmental health stuff, but also they lacked a consideration for equity and equity denied populations and the adaptation. So essentially practical tools did not exist. So we're like, we have a dream, let's create something. So to be able to create the PEHE-FAT, we used, once it was created, we used a Delphi study to validate it. This is just explaining how that process goes. And the team must have been amazing. But after 2 Delphi rounds, we obtained consensus, and then we followed up with an optional focus group to just chat with the people and the experts. So what is the PEHE-FAT? So essentially, it's a point of care assessment tool that also embeds the best evidence, educational evidence that was found to be able to deliver not only that assessment, but also education it's like a one-stop shop. Anyway, so this basically creates educational interventions tailored for perinatal families about air and water quality topics, et cetera, et cetera. So to access the PEHE-FAT, I put the QR code there. The PEHE-FAT has several different sections. So there's heat extremes, air quality, vector-borne diseases, climate change and disaster preparedness, food and water security, mental health, toxins and pollution. So it is very much a huge tool. With the tool, we also created a toolkit for health and social service providers, as well as families if they wanted to take a look at it, to be able to familiarize themselves with these elements. Because one of the things that came up in the research was that healthcare providers weren't aware of what existed, and they didn't feel like they had the capacity to deliver this information. So what I'm going to do right now is I am actually going to open up the PEHE-FAT so you guys can have a look at what it actually looks like. And please confirm that you can actually see it. Can you guys see the website?
Yes, we can see it.
Okay, awesome. I have to take a nod because this is my spawn that created the image here for us, which I find absolutely amazing. So this here up here is so up on the screen, you'll see like the full 1 hour and a half explanation. Right here, if you click here, it's a toolkit. With the next round of funding, we're actually going to be creating healthcare learning modules like LMSs for that to be able to really be more interactive so healthcare providers can learn. And we're hoping that they'll end up being accredited from the Medical Association and the Nursing Association, so Healthcare Providers Association. So if we click, for example, the heat extreme questionnaires, let's wait for it to open. It's the beta version. So this is something that we tested with the usability study, and people have used it in a variety of different areas. So they've used it in healthy baby sites. They used it in family centers. It was used at well baby checks in BC, prenatal screening when there was the wildfires in Manitoba. Public health used the air quality questionnaire to call the pregnant people on their roster to make sure that they were prepared in that eventuality because it was emergency. So they covered the climate and disaster preparedness and the air quality one. So a few things to note with the tool. We really wanted to be place specific. So you'll notice that we live in Manitoba, so I'll click Western. I live in Winnipeg. Yes, I'm pregnant. Let's age myself. and I have low income, but I'm housing secure. I'm part of the 2S LGBTQ population and Indigenous. So when we have that, you'll notice that as you play with the PEHE-FAT, you'll notice that the information that is then provided for the person in front of you gets adapted depending on how they identify. So if it's somebody who's a newcomer or Indigenous, we were able to collate evidence base that was more culturally specific. So for as an example. So if the other thing that we really made sure to do is any words that were higher than a 4th grade reading level is you can actually link it above and it'll actually have the definition on top of it. So when you're covering it with somebody, they can do it. So the idea for this tool is some service providers decided to put like different information with QR codes in their waiting room. So like if there was a smoke advisory, they'd actually put a poster up in their waiting room. Perinatal clients, while they were waiting, they could check the QR code, they could do the questionnaire themselves and then go ask questions after, because it's at that 4th grade reading level and they can look at it and then they ask questions. Other healthcare providers chose to do it with them on their mobile device. So if we click here, we'll see yes, submit. And then this ends up being a printout that you can then give the person at the end with all the collated best evidence. On occasion, I'm going to go back to on occasion, one of the things that we noticed is, as we noticed with the environmental scan and with some of the tools, it lacked actionable items. So if ever actionable items were not included in the tools, we embedded it based on the evidence within the anticipatory guidance here. So that way, if a tool existed, that was amazing. So for example, the top tips are in here and they're linked to it because that is already an amazing resource. Why wouldn't we? But other things were not as specific to pregnant people. So that was one of the things that we had to adapt based on the evidence and all the systematic reviews that we did. So I will close this down and come back here now. So there's a bunch of different sections. You really have to take a look at it to really play with it to understand how it works. So with this tool, we're on the next steps for the study. It was the beta version. So in the next round of funding, we plan on translating it into French. And then partnerships have been developed with Nunavut to be able to create a northern specific one, because one of the things that was missing while we were validating the tool was we did not have an expert in the field from the north. And so we are working right now with Nunavut Midwifery, Public Health, and Perinatal Services to be able to incorporate, for example, the latest study that they did on the environmental health concerns in Nunavut and in the Nunavunian context. When it comes to equity considerations, there are some of the sections that were a bit longer. So in the next version, we're going to split some of them up. So we're going to split up outdoor air quality, indoor air quality, and the toxins and pollutions. We're going to make it into more manageable sections. When it comes to health literacy, so far there was nothing really that we had to change based on the usability study. One of the things that was interesting is we had a super large team. So we had 10 people on the research team, all of whom were experts in the area. So when it came to actually finding the experts to validate the tool, we basically stole 10 of the experts that could validate this tool because they were part of the thing. That also might explain why it only took the 2 Delphi rounds to arrive at consensus. We also need, because of that lack of training, even though this tool exists, people are still nervous. So we want to create more training for healthcare providers to go in tandem. And this is there to fill a gap with the lack of tools. And the lack of awareness is basically something that we really have to work on. So that's kind of where we're at with the PEHE-FAT. I look forward to working with a collaborative and continue the work. I won't be able to talk about every single piece of what we've done because it's too much. Because 7 literature reviews with the 7 focus areas to develop the tool was a crazy task to undertake, but it was definitely worth it. So now we're basically updating those things to do the next round. So that is where we're at. Any questions?
Thanks so much, Jack. Any questions for Jack? And I think that I am seeing some really intriguing conversation and questions in the chat. So we're going to hold on to those to pick them up at the end so that we make sure that we give ample time for our fourth panelist. So my great pleasure to welcome Dr. Miranda Bevilacqua, Confederation College, who's going to be sharing some really inspiring and pragmatic work that she and colleagues are doing in Northern Ontario. So over to you, Miranda.
Thank you, Erica, and thanks everyone else for your awesome information, and Jack for your beautiful land speech poem. It was beautiful. So I don't have a lot of words on my slides. I decided to have pictures and just a little bit of a background. So what I'm doing is going to be talking about screening for mercury in our perinatal population. And all this information was derived from a study that I did with my colleague Rylan a couple years back. But first, I'll kind of start a little bit with kind of an intro to this topic. So we know geography very much determines diet. And if we think about where I am and those around me, right in Northwestern Ontario, we know that fish, it's not occasional, it's seasonal and highly cultural. So just a little bit about mercury. It bioaccumulates in fish. It crosses the placenta. Whatever level of mercury the mother has, the fetus, whatever level the person carrying the baby has, the fetus has as well. And then also, going further in that, when we look at breast milk, the transfer is lower, but it's still relevant. So the level of mercury that is passed through the breast milk is about 1/3 of what the person with who is breastfeeding has. And then something else kind of just to note, we cannot talk about, perinatal or prenatal nutrition without talking about environmental exposures. So let's look at kind of the gap and what is happening in practice. So from my 2023 study where we asked primary care providers and midwives about mercury levels and fish consumption in their patients, both perinatal and general population, the detailed data will be shared by Tim. But on a whole, we found almost 60% of providers rarely or never talked about fish intake. Over 85 never ordered mercury levels. Almost 60 never referred to the Guide to Eating Fish in Ontario, which I'll chat about later. And about 80% are not confident in interpreting mercury levels. So I just want to very much emphasize that this is not a knowledge failure at all. This is a system gap, which of course we've already mentioned the many gaps in the previous presentations. At the time of this study, we also found that midwives, specifically in Ontario, because I can't speak to the rest of the country, cannot order mercury levels. So we did reach out to the College of Midwifery in Ontario in hopes to add this to their scope, as it only makes sense for them to be able to order something that, they're already ordering blood work. Why would we, duplicate services just to have them refer out to get that requisition? Before we go to the next slide, I just wanted to mention, somebody had mentioned wildfires and all these climate change factors, mining, exploration. These are all things that actually impact the level of mercury within our environment. So for example, wildfires, the way it holds the mercury in the air actually creates more of an, I don't want to say necessarily an increase, but it allows the mercury to stay there longer. And then of course, when we have things like mining, which is, prevalent in all of our rural communities, once the soils shake up, we now have that leaching in the sediment, shifting, which now we see, coming into our watersheds and our lakes. Next slide, please. So Like I said, pictures. Here's my kiddo here with her Gigi and my husband in the back. So there's a clinical tension, right? We know how important it is to consume fish, but we also know there is risks associated. So just a little bit of a background: fish play obviously a critical role in fetal brain development. And again, like I said, for many communities, especially in our northern and indigenous regions, fish is not optional. It's cultural, it's accessible, and it's nutritionally essential. What happens, with exposure, mercury exposure? It depends on the species of fish, the source of fish, frequency of consumption, duration of consumption over time, because we know it bioaccumulates. And we'll talk a little bit about at the end of how we can safely consume for vulnerable populations. I want to be very clear that I'm not suggesting we stop eating fish at all. We just need to do so in an informative manner. And why does this matter clinically? Mercury toxicity, has impacts such as neuromuscular changes, memory loss, cognitive impairment, renal dysfunction, thyroid disorders, microcephaly, visual impairments, etc. Now, if we look at this from a northwestern Ontario, or even just a northern, lens, our Indigenous populations already experience higher rates of chronic kidney disease. So, and diabetes, prevalence is quite high. We know that mercury is, nephrotoxic. So if these exposures are elevated, it compounds already the existing renal vulnerability of our patients. The current safe levels are, according to Health Canada, are anything under 20 micrograms per liter for the general population, and then suggested to be under 8 for pregnancy and vulnerable folks. I just wanted to add that it's quite interesting because the state of New York Health Department, their threshold is under 5 micrograms per liter. And there's also some interesting data if you go to our Health Canada resources, and I can provide that. There is also a different value, or threshold for those working in in dental clinics, as well as Indigenous populations. So we need to kind of look at what does that mean, what should be the standard, and why do we have kind of a mixture of levels. But without testing, these thresholds remain theoretical. So the next question becomes, who do we test? It's not feasible at all to just go and test everybody. It's just not doable. So we need some direction. So next. So from our findings in our study, we developed this screening guide. It is available. Tim will share it. But before we kind of jump into this, I do want to say there are wonderful resources that exist. Absolutely wonderful resources, right? We've got the Guide to Eating Fish Ontario, and to be honest, I've done a scan of the country when I was doing this study. They vary from province to province. What I do like, and I'm not trying to give specific props to Ontario, but it's an interactive map where you can go and click on a specific lake and see the mercury levels in the specific fish. Now, having said that, we live in a country where there are, thousands and thousands and thousands of lakes. So the only, I guess, downfall to this is we don't have data for all the lakes. So there might be, specific regions or watersheds that we just don't have the information for. Another thing to note, it's unrealistic to expect, our nurse practitioners, our midwives to, map all these locations, where the fish is being harvested on their patients. So it becomes also this educational piece for our patients. But then we also need to think about, okay, some people may not be comfortable using internet-based tools. Maybe they lack reliable internet. Maybe there's language barriers. And maybe even, individuals may not use Western lake or fish names as the classifications are in these guides, which were created after settler contact. There are some interesting equations out there as well that providers and people can use, but to be very honest, they're tedious and a lot of information is required. I will also share that equation resource as well. So this brings us to how do we screen, right? So first, at the very first prenatal visit, maybe even all of our visits, right, regardless of what type of care you're doing. Do you eat fish? How often? What species? From which lake? How many years? Then we'll look at, higher risk indicators, frequent freshwater fish consumption, inland lake fish, cultural reliance, long-term intake. Have they had any previous elevated mercury levels? And these aren't things we need to necessarily ask each time, but just things that impact or have an impact on what type or how elevated their mercury could be. If we think there's a risk, order blood a blood level, right? NPs, physicians, they have this in their scope. Midwives currently face limitations unless this has been changed since my last discussion with the college there. But we really need to look at opening up scope for those folks working with folks who may be at risk, and then interpret, right? So using the Canadian thresholds. Maybe consider collaborating public health if levels remain significant. There might be something else going on. But let's look at some other factors quickly. So northern communities and rural communities rely heavily on wild game and fish. It is also very healthy and an organic source of protein that is generally unbothered, by human alterations and things like, antibiotics. But we can be smarter. For example, what's the type of fish? This is another thing I think I think we assume that if I eat a pickerel from this lake, well, that is going to have the same amount of mercury from a pickerel from this lake, and that's not accurate, right? We have to look at those different specifics, but also if we look at the size of fish and predatory fish. So predatory fish tend to carry higher levels of mercury than the non-aggressive species. Older fish also, that whole bioaccumulation concept, will have higher levels. So let's say you're at a feast and someone is pregnant or vulnerable, give them the smaller fish, give them the younger fish. I even said, to one community, if they had this huge lake trout that's probably, quite old, but instead of maybe, dividing that up between one family, maybe, divide it up between a whole community so that only small amounts of that are being dispersed around and include other smaller fish. I think also we need to look at wild game levels. This is something I'm trying to do with the government because they're eating fish as well, drinking the water, eating the lichen from the water bodies. Next and last slide, sorry. So just quickly, system level recommendations: develop and distribute a standardized screening pathway. I developed one. Might be a little bit wordy, maybe we can condense it. Further testing on other game, integrate mercury screening in the Ontario perinatal record. We have reached out to them and they did say that they will be revamping, so perhaps we'll see that in the near future. Increase provider education, improve accessibility and usage, or I guess usability as well of the consumption guidelines. And then again, heavily consider the scope of expansion of the midwives. And before we end, I have to do a little shout out. My own beautiful midwife is here, who helped with my two beautiful children. So I'm happy to see her here. And that is it for me. If anybody has any questions.
Thanks so much, Miranda. Any specific questions for Miranda? Yeah, fantastic presentation. Thank you very much for leaving us in a grounded way with the important work that happens in a community context with those adaptations. So we have a couple of conversations happening in the chat, which I'd like to bring into our open space at the end of our session today. So there was a question about, are there going to be, and I think this might have been directed towards the CPCHE presentation, are there going to be resources specific to pregnancy and or preconception? I do believe Jack's presentation probably answered that in part. But I do want to pose a question for all of us, participants, but also panelists, is is there a bright line there? We certainly know that preconception exposures for both mom and dad are relevant. Typically, the dads get left out of the conversation when it comes to prenatal environmental health protection, at preconception, I should say. So what are the approaches that we need? And I think there's never just one approach. I think in the work that we're doing with CPCHE, we are trying to build that community level literacy through frontline service providers capacity. to embrace an all of family and in fact an all of community frame, rather than focusing specifically on pregnant moms. And there's lots of reasons that we can get into, but I certainly hear you in that question, because there are specific needs for information during pregnancy about what about this chemical, what do I do, and some of the examples that Miranda gave. So the floor is open for anybody who wants to dive in on that question of, do we tailor specifically to pregnant persons? Or is the game here really to build that, that broader literacy across families and in a community setting?
You can start if you want, Erica.
Yeah, Jack, thank you.
So I think that's one of the things, like even in the creation of the PEHE-FAT, because this is like more of a systems issue, and we recognized like with the PEHE-FAT, it was for families during the transition to parenthood. So it wasn't just like the pregnant person, it was also taken into consideration, like if they are looking after an older parent, if they like who their family is, and tailors questions more than just the pregnant person. And I think to be able to support pregnant people, the changes have to be made at the family level as well. So like we have no choice but to include. And given that it does influence, why are we not including other partners in the conversation? But there's less literature, which is a little bit harder to be able to integrate. But when we're looking at this systems level, it should start way earlier than when somebody just decides to be pregnant or wants to have a family. It should start like as soon as somebody is born. You know what I mean? With like making healthy choices.
Mm-hmm. Thanks, Jack. Does anyone else from the panel want to jump in? Yeah, and you know, we have only one more minute, but I do want to flag something important that Miranda brought in, which is those systems level gaps as well. So it's not just a matter of having brochures and websites and great social media posts. It is also about the capacity of agencies and providers to engage on these issues, to be supported. But often there are systems gaps that impede that action. So if anyone has any experience that you want to share of, you know, we try to address these things, but just here are the sorts of things that stand in our way, love for somebody to hop off mute and share a quick example, or in the chat. And I do just want to acknowledge there was also a conversation in the chat about emerging concerns. So microplastics, several of you were saying this is an issue. Speaking for CPCHE, in our top 5 tips backgrounders and in the resources that will ensue, we are looking at that in the Get Drastic with Plastic frame, but also in fish, right? So if fish are in waters that have microplastic contamination, which is ubiquitous, are those questions starting to come at the front line, or perhaps should they be something that's on the collective radar? So microplastics, and then certainly products that have forever chemicals, the PFAS chemicals. So what are some of those areas where product categories have chemicals of concern, and building that knowledge among service providers and also the public more generally. So I'm really sorry that we are out of time for today, but I do wish on the behalf of all of us involved in this project to really thank our speakers, and also equally to thank all of you for being here today. You'll see that we are inviting you to share of resources that you know of, resources that you've appreciated, strategies that you use or wish you had support to use. The door is always open, so please let us know. And as I mentioned, we are trying to coalesce people's ideas and asks into sort of a roadmap for going forward, so that we can do this collective work in Canada to build these important capacities and support families and communities to understand and protect against environmental exposures, but also to be that informed citizenry that is going to be asking for and demanding stronger protective policies. So with that, I'm going to say thank you, pass it over to Tim for any last minute housekeeping, and then we will draw this webinar to a close.